So thank you very much. I think we are covering every aspect of radical prostatectomy, and probably this talk is not really needed because we don't have complications, as we know. So I just finished my talk, no complications. Costa? I think I won't discuss the preoperative evaluation because obviously it's very, very important. The complications of positioning and complications of access is not really related to radical prostatectomy. You can have it, and I won't discuss, but I will stay for the intraoperative surgical complications and the early postoperative complications of radical prostatectomy. And I tried to keep it as simple as I could because it's an extensive topic. And just to give you some ideas for discussion after the end of the talk. The late postoperative consequences, because I don't really believe we should consider them as a complication, the continence and the impotence. I have some slides. I will pass them quickly because I think both Stavros and the other colleagues covered this topic quite extensively, but we will also discuss about that. So overall, the incidence from systematic reviews, recent systematic reviews, is approximately 9% of a complication. So it's low. And the most common ones is the lymphocyl, the urine leak, the need for reoperation, which is not that small. The perioperative mortality, thanks to God, is really small, and the Clavian 3 to 5 complication rate is actually very, very low, which is quite important. Just to remind, 3 to 5 is the need for re-intervention, and 5 is the death. The perioperative mortality is low. And if you go to very experienced centers, and this slide is a little bit blurred, you can see that the complication rate is really small. So with experience, the outcome is better and the complication rate is low. Bleeding during the operation, thanks to God, the vast majority of the bleeding comes from veins. And most of the time is more easily to control. So it can come from the venous structures and the DVC. When you do the lymph node dissection, the iliac vein can be injured, and it happened a couple of times in the past to us. And when you don't dissect very anatomically or you come very close to the prostate, then you have some bleeding. Of course, you can pack and wait, you can suture, you can buzz, you can do different things, but don't forget that you can also retract the prostate, and you can decrease either yourself with a fourth arm or your assistant, or even during the open surgery. Rectal injury, as I said, is very, very uncommon, but it can happen, and you always have to consent the patient beforehand for this injury. Usually it's during the apical dissection or when. So it's the first time that they fixed the microphone for me so many times. Thank you. Or during the attempt to develop the plane between the rectum and the denon-villus fascia. And most of the time, the most difficult issue, as you all know, because you are all experienced, is very crucial to identify intraoperatively. If you identify intraoperatively, you can fix it. You can finish the operation, you can clear the field, you can have a good hemostasis, you can do the 2 layers after that if you identify. The problem is if you don't identify intraoperatively and the patient becomes ill afterwards. Then don't be afraid, it's not the same, that you may have to divert the large bowel if there is an extensive lesion, or if the patient had previous radiation in the area. Obturator nerve injury, although doing a lot of them we didn't have up to now, but usually it's during the lymph node dissection, and you can reapproximate with some non-absorbable suture. The ureteral damage in open surgery, I've never seen it. In my robotic career, I have one ureteric injury. It's not a very good complication to have. Usually you can have it at the bladder neck. This is more difficult, I think, if you have it at the bladder neck. The injury that we got was during the dissection of the seminal vesicle, and we performed an end-to-end anastomosis, although the literature supports the reimplantation on these cases. The case went well. Again, you have to recognize it intraoperatively, and you have to know how to fix it. If you don't know how to fix it laparoscopically or robotically, you can convert to open surgery. It's not the same. Major vessel injury, usually during the lymph node dissection, and it's the common iliac or the external iliac or the hypogastric arteries and veins, most commonly the veins. And you can, if you have a small venotomy or arteriotomy, you can suture it with Prolene sutures. If there is a major bleeding, and you are not being able to fix it, then conversion is not, as I said, the same, is not a problem. You have to do it. The most difficult issue is when to decide for the open conversion or for to take change the access. I think as a rule of thumb is if you have already your anesthetist has had the need to transfuse the patient with a couple of units and you are not able to finish with a fixation of the vessel injury, then you need to call someone or to convert. That's a rule of thumb that I have in my mind. Post-operative complications, again, as I said, it's not that high as an incidence. Again, if the bleeding, you can have some bleeding, and if the drain is draining a lot, then you have to make a decision when to come in, or if needed, and what exactly you have to do. Again, the rule of thumb is if you have to transfuse more than 2 blood units and it doesn't stop or the patient is deteriorating, then you have to do something. And there is some evidence, not high quality of evidence, that if you go quickly and fix the hematoma or the bleeding, then the recovery will come, the recovery of the patient is better, and the continence comes back earlier instead of leaving the hematoma. But as I said, there are some other studies not really supporting this. This slide, I just put it for some of my friends in the room because they are using it, the tranexamic acid. There is very little level of evidence. Probably could be of some help, at least to my coronary vessels, and I think nothing more. Major bleedings, you can embolize, and I think I saw that after a TURP when I was in UK. I didn't believe that you can really embolize when I was younger small prostatic vessels, and this is feasible, and you have to think it before you make a decision to convert. And there is some evidence behind that the patient really has by far a better recovery. Lymphoceles, as I said, probably it's the most common complication of the radical prostatectomy. Of course, if you perform, or if there is a need to perform, a lymph node dissection. So you may have it up to 6 or 7%, but the clinically significant that causes symptoms to your patient is lower. So you may not realize that the lymphocele is there because it doesn't give trouble to your patient. And although you think that you have done an excellent job, the small lymphatic vessels can open again after a couple of days, and your drain, or because you may not have a drain after a couple of days, the leakage may start after a couple of days. Sorry. Probably the lymphocele is the only complication that really differs among different surgical operations, surgical accesses, and we'll discuss about that. It may give no symptom, as I said, but a palpable mass or a ureteric or vessel compression or most commonly, the patient will get some fever after a few days or even after a couple of months. And this actually happened to one of our cases. Now, what to do to avoid clip every single vessel or buzz every single vessel or ligate every single vessel? Well, I was thinking when I was trained, and still I'm trying to clip everything, but I'm not 100% sure if this really prevents from the lymphocyte, and I will leave it open to discussion. And of course, if it really becomes symptomatic, then you need to drain, you need to make a window if you stayed extraperitoneal to the peritoneum, or you may use some sclerotic agents that I've never used in the past, so I don't know if they really work or not. As I said, probably if you go extraperitoneal, the lymphocyte rate is higher, and and if you do bilateral lymph node dissection, it makes sense, and extensive lymph node dissection, it makes sense that you may have a higher rate. And another issue is if you cut within the lymph node, and if the lymph node is eventually positive, then the lymphocyte rate is higher compared to if the lymph nodes eventually are not higher. Now, urine leak. It's my ultimate fear because I think it prolongs the recovery of the patient. And you can have it. It's not as high as 15%, but in some series you can have as high. And the problem is to recognize it. If you have the drain and you collect every single spot of urine outside from the body, then there's not a problem. Probably you may have to wait. We had a case that we had to wait for 21 days, and the 21st day, the urine leak stopped after the previous day was giving 1 liter of urine, and it stopped automatically. The patient didn't believe, and probably didn't believe either. It really depends on whether the urine are leaking inside the peritoneum or extraperitoneum. It makes a difference. Now, both the rectal injury and the urine leak, the patient may come back with pain. So if the creatinine level at your, in the blood is elevated, then you may probably have a urine leak. If it is normal, then you may probably have a bowel injury. And you do perform a CT scan, and you have the right answer. Bladder neck contracture and is not that high. In the past, that we did a lot of open, and still we do a lot of open radical prostatectomies. The extensive reconstruction with extensive suturing, we had bladder neck reconstructions. I think a good trick that I learned from John Varkarakis is the Babcock clamp to reapproximate it. I didn't know that, and when I'm doing difficult open procedures, I use it, and I think this is the good reapproximation is the key point. Sorry. And I think also, as I said, that the slides say that the correct reapproximation is good for the bladder neck construction and for the urethral strictures also. The problem is if you have a real urethral stricture, what to do? Because we are talking about a posterior urethral stricture, and I leave it open for discussion because a lot of people say that we need to redo the anastomosis. And I think it's extremely, extremely difficult operation, at least in my hands. Surgical complications. Complications are not only surgical for many reasons, because of an extensive operation, because of the lymph node dissection, because of the blood that we are losing. You may get emboli. So I think this is quite important to know and to follow the guidelines. I won't stay and I won't discuss every single one of them, but I think it's very important to know that there is weak, most of the time, evidence behind that, and I think that you need to discuss with the patient what to stop, and with the patient, but also with the cardiologist. Although you have to keep in mind that although the cardiologists say keep on going with the anticoagulants and you may operate with them, and they don't have to stop it at all because they are in danger, think if you give another alternative as a therapeutic measurement for your patients instead of being operated. Now, as I said, I will go through very quickly of urinary incontinence and erectile function, because I think are there complications or sequel of the radical prostatectomy we need to discuss? And as I said earlier this morning, we need to preserve, reconstruct, and reinforce. That was my morning talk. Preserve the bladder neck or everything that we destroy, reconstruct anterior or posterior, and do a very good anastomosis. And as I said this morning, I don't believe in the reinforcement of the bladder neck. The post of the erectile dysfunction, Stavros covered everything very nicely, so I don't have to say anything more. I will agree with Stavros that whatever we did the last 10 years, we didn't change a lot in potency rate. And I think, from my point of view as a complication, the rehabilitation regarding the potency is important, especially if you don't do anything, then the patient will stay impotent. If you do something, then you have to have some results, positive results for your patient. And this is a meta-analysis of the potency. I will go through this because Stavros really covered everything in a better way. So this is a good message. The early initiation of the rehabilitation of the medication, the higher dose that you can give of tadalafil, let's say, the longer course of treatment, and if the patient has had mild erectile dysfunction after the operation, then the better chances you have to have potency afterwards. If he is totally impotent, then the oral medication, as you know very well, they don't do a lot. And I'm finishing the talk with the difference between the different accesses, open, laparoscopic, or robotic. A lot of meta-analysis, as I will show you, a lot of them, Lancet, major, no statistical difference, not only in the oncologic outcome, but only in the complication rate. Again, other, no statistical difference. Major randomized control trials, still more meta-analysis, recent ones, no difference. And the reason I'm putting these 3 slides is to say no difference in the complication rate. So thank you very much for your attention.